I don't even know what she asked. Hey, babe, how many hot dogs do you want?
Oh, hello. Can you hear me, Erica?
Yes.
Hi, Michelle.
Good afternoon, Ross. Russell. Good afternoon, everyone.
Hi, Michelle.
Please accept my apology for being off camera today.
Yeah, it's okay. You don't need to apologise. Hope it's all working out.
Thank you.
Did you see that nice patient letter that's forwarded, Glenn?
No, I was just having a longer conversation. I plan to with another CFO elsewhere in the group, but I will have a look for it, Russell.
Erica, do we have any questions at the end? I haven't seen any, I don't think, come through.
I haven't seen any either, Chair. Can I ask who Chris Byrne is?
Isn't he a member of
Health Watch.
Yeah, I won't say Health Watch. It's Hi, Chris.
Yes.
Oh, hello.
Good clue there, Erica. Hello, Chris.
Hello. Yeah.
Russell, just to let you know, the live stream's up and ready to go, so we'll start whenever you're ready to start.
Thank you, Richard. Very smart, Stephen, very smart. Looking like an air traffic controller with that headphones on, Ali.
I'll try not to behave like one. Thank you.
Will keep us all safe. Nice to see you, Justine. Okay, Richard, we'll get going then, if everyone can go on to mute. And welcome, ladies and gentlemen, to this the April Worcestershire Acute Board. We've had a busy workshop session this morning. We heard from one of our patients, Ron, who was sharing his experience of being in the Alex, which was very helpful. We then had a substantive discussion on the financial recovery plan for the Trust, which we will brief to members of the public next month. We then had an interesting discussion on culture and values within the Trust, and a significant piece of work is going to be undertaken in coming months, where we want to hear from colleagues as to how they would like the Trust to be and how they would like us to behave. And finally, we had a session which was a board evaluation summary. So very substantial amounts of work already being undertaken. Lovely to see members of the public with us and friends from Health Watch and elsewhere. We have apologies for absence from Vicky and Sarah, so thank you for colleagues standing in for them. Erica, I don't think we've got any other apologies at the moment, have we? Okay, any new declarations of interest? Would you please raise a digital hand if you've got any new declarations of interest? Julie raising a physical hand. Julie.
Couldn't find the knob in time, sorry. I've just taken on being chair of a non-profit hearing aid company that's going to develop and make hearing aids for the developing world.
Sounds like a wonderful charity to be involved in, Julie.
I'll send that through in writing. It's only just happened.
Okay, congratulations and thank you for that. Any other new declarations of interest? Okay, we'll move on then to the matters of the minutes of the meeting held on the 12th of March. If you're unhappy with the accuracy of any of those minutes, could you again please raise a digital hand? Okay, I can't see any digital hands raised, so I'll take them as an accurate record. So we'll go then to, I think it's just page 9 of our board pack for the action schedule. And there were 3 actions. The first was on the integrated performance report, and for national guidelines adherence by community hospitals practice to be discussed with the Partnership Trust. I think this is ongoing, isn't it, Sue, with Sarah talking to them about, I think, the discharge protocols and infection prevention control protocols. So please keep us briefed on that as it develops. That's due back in June. We then had the BAF and risk appetite that they presented for the next meeting. That will now happen in June. So thank you for that, Erica. And then the final one is there is a lot of work going on. I do want to assure members of staff who might be listening to this, we are working as a board vigorously to try and find practical and workable solutions to the car parking problems we know you have. And it is often a case that when we come up with an idea, it gets knocked back for whatever reason. But I know Stephen is personally taking this forward with passion to try and find solutions. So we will update you on that as soon as we can, as well as we're looking at the reception desk in Worcester to try and make that a more effective sort of arrangement to signpost to patients and their families where they need to go. Are there any matters arising that colleagues feel I've missed? Could you please raise a digital hand? Okay, we'll move on then. An awful lot going on in the NHS at the moment. We've just finished our financial year. And Glenn, therefore, how are you seeing the various different challenges we're facing?
Thank you, Chair. Probably planning. A lot of planning is going on at the moment, is the best word to describe the current phase of the NHS. I'll take you through the headlines of the report. And firstly, I start with the planning guidance, which is a new record for the NHS in that it was published 1 working day before the year in which it was coming into effect. which didn't give us lots of time to react, but I think it's also fair to say there weren't any huge surprises in there. I provided a summary of the main targets and milestones in there. Just to pull out a couple of things. Firstly, on urgent emergency care, rather unambitious plan to move from the 76% we achieved or set out to achieve in March of last year to a 78% milestone for March at the end of this year. On the elective recovery plan, the 65-week wait milestone has been moved to 30th of September. There is no 52-week milestone in the planning guidance, which is interesting, and I'll probably come back to that in a moment. Also a big push there on achieving high levels of day case and theatre utilisation, which is obviously an important part of our efficiency plans. Cancer waiting times milestone 62-day standard to 70% by March, and the faster diagnostics standard moving to 77% by March. But then the report turns to the kind of main thrust of the planning guidance, which is quite a bit of focus on productivity. I mean, what we see really in financial terms is a steady state financial plan, and it's probably worth emphasising within that there are assumptions around inflation. There's a 2% provision for pay awards. So if pay awards are higher than that, then that will either present us with a bigger efficiency challenge, or we will need additional funding. But we're starting to see some more data on the relative productivity of individual organisations. There's a workforce productivity tool which we'll be working through as an organisation as well, which looks at the changes to our headcount from the 1920 baseline year to today. So that will give us some pointers as to where we could improve productivity. The aim for me would be to ensure that we deliver more activity in a number of different ways for the headcount that we've been able to recruit to. So that's and that will feature as part of our financial plans for the year, which we'll talk about in a moment. There's then a bit of analysis on the staff survey. So I'll just draw your attention to the table that sits on that third page of the report, which has been produced by NHS England engagement lead. The staff engagement indicator for me is one of the most important indicators in the entire survey, and the survey is the most important indicator of performance to me. So just draw your attention to where we are on that. What this looks at is the improvement year on year, which is on the y-axis, and the overall engagement, which is on the x-axis. So where you really want to be is in the top right-hand corner of this chart. So high performance, but still improving. We're in the left-hand segment. We're not going backwards in terms of our engagement score because we are above 0. But if you look at the blue line that cuts across the y-axis, that's where the rest of the NHS are. So we've seen a general improvement in engagement, and we're slightly off the pace on that one. So huge focus for us over the next year will be to move our position over to the right-hand and top right-hand side of that chart. And there's lots of evidence, and I strongly believe that if we do so, then lots of other important things for patients will follow on from that. I talked through the spring budget when we last met, so I won't draw out any of the detail there, but the detail's there if people want to have a look at it. The one thing that I did want to pull out is on the next page, which is around agency staffing, particularly the high cost agencies, so the off-framework, as they're referred to, agencies. There's going to be a very big focus across the NHS, and I'm really quite supportive of this July 24 milestone, when the aim is that every NHS provider will stop using off-framework agencies. Now, that won't be easy, because when we do so at the moment, we're doing so having made a judgment about patient safety. But if those individual nurses or doctors who are on those high-cost agencies can see that we're not going to use them anymore, then hopefully they'll make themselves available either coming back into employment at the NHS or on our bank or on the framework agencies. So I think it's an important test of nerve of the NHS that those staff can come back. And it's not my concern actually about a lot of this is it's not so much what those individuals are being paid. It's the very high rates that these agencies are charging for on costs. And some of them up to 60% of the charge that we pay is going to the agency itself, not the individual member of staff. And I did some analysis on this because the BBC have done a piece on it. And you could employ 10 nurses for the cost of one nurse on the extreme bank holiday rate of a particular agency, which the BBC will feature. So it's really important for us to spend that money on direct patient care and to have as much of a workforce as we possibly can. And our numbers off framework at the moment are pretty low, but as I mentioned earlier, they're generally in areas where, for example, critical care, paediatrics, where it's really hard to close capacity down if you don't have the staff. And if a nurse calls in sick over a bank holiday period and at short notice, it's often a difficult place to be when you're an on-call director trying to manage the site. But hopefully we will see that through. I talk about productivity improvement, the work we're doing across the group on that. We are in a unique position that we have the ability to compare and contrast much more because of the group arrangement and the work of the group analytics board to ensure that we're comparing apples with apples has been an important part of that. And what we do in our full boards meeting when we meet on a quarterly basis. I'm then promoting the Foundation Group Improvement Week, which is May the 13th to the 17th. All 4 trusts taking part on that, a virtual event, and real opportunity to share the best practice that's going on across the group. And then finally, giving some focus to the acute frailty unit team who have enhanced their board round process. And it's really good to see the frailty team expanding because in these difficult financial times, this is one area where we absolutely do want to expand our capacity. It's in our 10-point plan. I'm really pleased to see we've got a new nurse consultant that's joined the team, and we'll be seeing a lot more from that team moving forward. But it's good to see the work that they've done on improvement. So I'm happy to take any questions, Chair.
No, that's fantastic, Glenn. And as Glenn's indicated, and I'm sure Stephen will, in the integrated performance report, a number of our operational metrics are improving, and thanks to all of the team for that. But the reality is we're still a long way from where we used to be as an NHS, and we as a team are absolutely determined to deliver the best possible care we can for the people of Worcestershire. Questions and perspectives to Glenn? Okay, we'll move on then to the integrated performance report. And Stephen, do you want to get us going by giving us an overview, please?
Yeah, so just kind of picking up on as you said, Russell, actually this one is one of those difficult ones where because we're dealing with this in real time, we kind of have a much better feel for where the metrics are actually landing at year end than the report highlights. I will just put Sue on notice that I may come to you first, Sue, when I've finished, because Helen is just finishing a system call. So just to do that, but I think my general overall view at the minute is we've still seen quite a sustained pressure, certainly within urgent and emergency care, and some of the attendance numbers have still remained the highest that we've experienced. So that's the background that we've been working within. But within each of them, there's signs of encouragement and improvement that when Helen does join, she will talk through, particularly on the operational performance at year end. But I think I wanted to pull out, as you said, Russell, we've kind of got to keep it in mind, as much as it's encouraging and it's improving, it's nowhere near where we need it to be. And that's the focus that we've got to move on some of those standards, particularly around people that are waiting for our elective procedures for cancer. And still we we still put a lot of work into our ambulance handover delays because unfortunately too many patients are still experiencing delays. Largely that's not down to the emergency department. That's the work that we need to do as a trust and as a system on our length of stay is the key driver behind that one, really. But that's all I was really going to pull out, and I was going to hand over to the individual sections, if that's okay.
Okay, that's super. Thank you. So Sue, over to you, given Helen is just finishing off her call. Sue, do you want to cover off the quality and safety aspects first of all?
Thank you, Chair. So just take the report as read, but I'll pull out the salient points. So just from an IPC point of view, they've continued to have numerous ward closures due to norovirus and COVID outbreaks during February. But to note that Akenbury Zero has been reopened following their extended outbreak, and that's now been restricted to 21 beds. And then we've seen no further outbreaks in this area since we've reopened it, so that has worked really well. They've also got estates worked planned as well to look at the toileting and showering facilities over there, which was well received by the team. The compliance target to close within 25 days has been achieved in February. We're at 81.8%, and just to note, that's the first time we've been compliant with that target since June 2022. So again, some good news to share. Still got a focus in the surgery division, but they're working on a process for sustaining their better response rates. Our total number of falls remains below the national benchmark again in February, and there's been no falls with harm during that month either. And there was also 0 hospital-acquired pressure ulcers with harm caused during February. We have dipped on our friends and family response rates and recommended rates, just to note, but our patient experience lead nurse is working closely with all divisions just to ensure that that momentum is sort of retrieved and maintained. We have added in an additional inpatient survey, which we think just may have affected that, but there's certainly a focus back on that on the wards through March and April. So those are the points I wanted to pull out. Thank you, Chair. So happy to take any questions.
Okay, great. Really encouraging to hear the news about the hospital-acquired pressure ulcers. For members of the public, that's often a lead indicator for the quality of care given, and you want that number to be as close to 0 as possible. So before I move on to Jules and Julian, any questions on what we've heard from Sue? Simon?
Just a congratulations actually on being equal best for MRSA across the region. I know we've still got challenges at IPC, but congratulations to the whole team on that. That's brilliant.
Thank you. I'll pass that one, Simon.
Thank you. Tony?
Yeah, thanks, Chair. Yes, a question on page 26 of the packet is the IPC slide page, and is the first action listed on the page. It says it's a reference there to a lack of assurance regards line management around the EPR. I just wondered if you could perhaps explain a bit more about what that concern is, and then after that, I've just got one observation as well. Thank you.
Thank you, Tony. So the reason we put that as an action is we have seen more MRSA bacteremias being reported. They're not attributable to the trust. We've had 7 to date, with 1 being attributable. But actually, sometimes what we have to look at is very close monitoring of our peripheral venous devices. That's what we're talking about, lines and central lines that go in. It's where we give medications and fluids. We audit those 3 times a day, every day. So what we check is if we're having an increased incident of line or MRSAs, we check that compliance with that audit. So actually, whereas we would normally audit weekly, we've gone to daily monitoring on a lot of the areas that have been affected. And what we're seeing actually is that we are compliant with that auditing. So we haven't seen any themes or issues being raised from that increase in audit, which is good news.
Okay, thank you, Sue. Thank you, Tony.
Thanks. My observation, just if I may, Chair, is on page 29, which is in relation to sepsis. In the risks box, I think we've just got a transcription over there, because I don't think those risks relate to sepsis at all. Just so it's just a correction to be noted, I think, for future. Thanks.
No, thanks, Tony, for that. You're correct. And Glenn?
Yeah, my question was on the infection prevention benchmark. Obviously, the CD difficile position particularly is concerning compared to other parts of the region. Now, obviously, we've got two inpatient sites that are, one's older than the other, one's PFI, one isn't. Is there any discernible difference in performance between the two sites?
Nothing that we've picked up, Glenn. No, it's across both sites, and there's no particular ward areas. It is across general ward areas. Again, we do a lot of auditing. They're all reported through our TIPSI meeting, and there hasn't been a lot of omissions in care or gaps in care that we've been able to identify as to make those attributable. But they're all investigated individually and taken through the TIPSI meeting for assurance. But no particular themes or issues are emerging from those reviews.
Okay, thank you.
Thanks, Sue. Okay, and Jules and Julian, anything you wanted to add on the quality and safety part of our board report?
Thank you, Chair. No, nothing additional to that that's written. Happy to take any questions. Tony, if I can just come back to your point, the 3 risks there do relate to sepsis. If you can't get a patient off an ambulance, or if your ED is crowded, it impacts on your ability to deliver your sepsis bundle within 60 minutes.
Thank you for educating us all there, Jules. Any questions to Jules? Sue?
Thanks, Jules. And I know you've only recently inherited this, but for 4 years we've been hearing about neck of femur issues. And I know our mortality figures are good, but nevertheless, and on page 32, there aren't actually any actions. They're just descriptors of the performance. And I wondered what was going on in the background, because this has been a problem for 4 years.
Absolutely. So there is work going on with that, which I'm sure Helen will talk to as well. So a protected neck of femur bed is the most recent kind of item being piloted, but I'll make sure there are some actions coming through, because there is stuff happening without a doubt, because this is an area where we do need to improve.
Yeah, I thought I'd heard about the neck of femur bed. I thought it just got missed off. Thank you.
Helen, anything you want to add? Otherwise, we'll move on.
No, that's fine. I was just going to reiterate what Jules was saying. The only other thing we are going to be looking at is right sizing the TNO bed base so that we can pull those patients right through. We're also trying to look whether we can use the surgical assessment unit to move patients out of ED quicker, so that they're actually being cared for in the surgical specialty. So there's a number of things that we're just working through. So.
Okay, thanks, Helen. Well, we'll segue back then into the operational update, Helen. I know you've had a busy time of things. How are you seeing things generally? We'll take the report as read.
Okay, thanks, Russell. What I would like to do is just, so the report's read and you'll see some of the challenges that we've had during February, but what I probably would like to do, and apologies for being late because this sort of almost contradicts what I'm about to say, is talk about March, where we were from at the end of March. And so everybody will be aware of our sprint to try and improve our urgent and emergency care performance across all of our metrics. And I think what we have seen is, now we look at the end of March, we saw across both of the organisations, we saw a 7% improvement combined for our EAS target. It was actually a greater improvement that we saw at the ALEX. The ALEX had a 15% improvement. We also saw an improvement across every other single UEC metric. So against the highest number of attendances that we've seen per month, we saw a reduction of over 100 over 60-minute ambulance delays. We saw improvements in our highest numbers in patients going through SDEC. We saw highest numbers of discharges before 10 a.m. So really, many of the things that we've done in terms of improving that, we're trying to stick with. It's about some of those processes rather than putting some of that extra capacity in. So really, really great piece of work done across the UEC footprint. The other things that we saw some success in is our cancer 62-day backlog. We've been tasked with, and you'll see within the report, of trying to get our backlog down to 190 patients who were in the backlog, which is part of the National Fair Shares allocation. What we did end up doing is we delivered a backlog number of 141, which is 26% under what we were asked to deliver, which is really, really good. It's really positive. So really drove those numbers down. So fantastic work from all of the teams to be able to do that. And we delivered the faster diagnosis standard for March as well. So some real improvements across our cancer pathways, but improvements for patients. And we're continuing to drive that through the work that we're doing. And then from our long waits, from an elective point of view, unfortunately, we didn't get to 0, but we got to where we thought we were going to get to, which was 29 patients breached the 78-week target. However, we are still on track and we're pushing for 0 for April. So whilst it feels really challenged at the moment, so apologies for being late, it is a challenge, a really challenging day. We are still seeing some of those improvements coming through across our elective care, our emergency care, and also cancer. So small shoots, Russell, but we are starting to see those improvements.
Great summary. Thank you, Helen, and thank you for your and all your team's hard work in the background. Glenn, anything you want to add before?
Yeah, I just wanted to say well done to Helen, but to everyone in the organisation who's contributed to that. It was not an easy position, particularly over a tricky winter. So it's great to see us doing better than anyone would have expected against those milestones. I think also, I know it's tough at the moment, but it's also reassuring that there's still some other things that we know we can improve, particularly some of those exit pathways from the hospital. So we'll not lose focus on those, as well as hopefully continuing all the things that we've put in place to improve things within the hospital.
No, well said. And just before we move off that point, clearly, with system partners, we do need to make sure flow into the community setting occurs much more smoothly than it currently appears to be occurring. And I would make the general point to members of the public that home is often the best and safest setting for your health recovery. Hospital-acquired functional decline is a scientific reality. You shouldn't be in a hospital when you're medically fit to go home. So home is definitely the best place for you if you don't need an acute setting to be looked after in. Richard?
Thanks, Russell, and also Helen. Yeah, so absolutely great news, I think, on the UEC metrics and some of the others too. I was wondering, and this is maybe attached to Glenn's question, do we see any effect on length of stay, Helen? And do we know to what extent length of stay is influenced by our inability to discharge? And what's going on with the theatre utilisation, which dipped a little bit, I think, in previous month?
Yeah, thank you, Richard. Length of stay is quite a tricky one at the moment. We haven't seen a huge impact on the Worcester site around our length of stay. We have seen that start to improve across the ALEX, but we are seeing some challenges in terms of particularly patients that are on some of the pathways, their length of stay increasing. So we've done a big piece of work around being much more action focused within the discharge hub to try and drive any of those actions and get them much more in a timely way so that patients can be discharged quicker. And actually it's around some of that, getting patients home, as Russell was saying, around that hospital-acquired functional decline. The longer they're with us, the more decline they have, and then the more care. So length of stay, we've currently got our eye on really closely. Obviously, we're diverting quite a lot more patients away from admission. So the single point of access is working really well. Our consultant nurse started last week. And actually putting that real drive in alternatives to ED, and that's why we've seen some of the biggest numbers that we have done going through our same-day emergency care. And with our frailty assessment area starting next week. In terms of that pull out of ED straight into our frailty assessment unit, we should start to see some of those length of stay metrics start to come down. So I think it's watch this space, Richard, on that. So, but really, really pleased with that work. From a theatre productivity point of view, you'll be aware that Kidderminster received its accreditation for the elective hub. So we are absolutely driving that now as hard as we possibly can. We've got our first day case knee out there coming up, and so really looking at how we maximise all of those opportunities through all of our theatres, understanding what's funded and what's not funded, and how we can drive 3-session working, 7-day working, all of those things through that. We're part of the next wave for the going faster further from a GIRF point of view, and so we're embracing all of that, Richard. So it would be good if we could provide you with an update outside of here, but there's lots and lots of work ongoing, and it's really exciting actually to see the work that's coming on.
No, great, thanks, Helen. Length of stay is such an enormous opportunity for us, but again, I would like to put on record my thanks to all of our clinical theatre ward teams who are adopting innovative and more flexible approaches to drive productivity up and length of stay down to the betterment of our citizens. So thank you to them as well. Tony?
Yes, thanks, Chair. Helen, it's on the urgent care page, which I think is 19 in the pack. There's a reference there, the last risk that you list there is insufficient alternatives to emergency department for patients with urgent non-emergency needs. I wonder if you could just clarify for us, is that a reference to our own provisions or to other providers' provisions being developed further? Thank you.
Yeah, thanks, Tony. I think we've got a mix in there in terms of patients that could be seen in the community, so urgent community response. It's around making sure that patients are redirected to some of the primary care appointments that are there, and patients being able to access them. And then one of the things we are looking at is the length of time that we need our same-day emergency care units open. So I think there's a mix of things within there that we could do better as a system as well.
Yeah, I mean, it's definitely important for us to be working with system partners and for them to be working with us. This message about hospital-acquired functional decline relates as much to the community bed setting as it does to the acute bed setting. So home is best generally. So with that sort of comprehensive briefing, we look forward, Helen, to the continued progress that we've seen in March, and we'll move on. Ali, welcome. Again, Ali's only now been with us about 6 weeks, but it feels so much longer, Ali. How are you seeing things on the workforce side, please?
Thank you, Chair. So from the workforce side, there's a few highlights I'll just bring to your attention from the report. Vacancies are continuing to progress, reduce in a positive way. We're almost 300 less vacancies than we had this time last year, which is tremendous progress for all of the teams involved. I will balance that with, we know there are some hotspot areas, notably AHPs. We do know that we have vacancy issues there, and we are keeping an eye on retention in that area as well. And there are pieces of work going on there to look at how we can best support our AHPs to grow their career with us and stay with us. And also there are medical vacancies, which we do know is contributing to the medical agency spend picture as well. So positive news in terms of the vacancy reduction, but we are keeping our eye on some of those hotspot areas. In terms of that medical agency challenge, there is a piece of work that I've referred to actually in the meeting chat as we've been going through as well, which is really just trying to coordinate all of the activity that we are undertaking to try and reduce that medical agency spend. We know that that's not just about recruitment, but it's also looking at how we support better rostering, how we control demand through really good job planning, but also making sure that when we do have no alternative but to procure agencies, we are avoiding those off-framework agencies that Glenn mentioned before, and that we are procuring for the very best cost that we can procure agency work for, and that we're keeping tight grip and control on those prices at the same time. Part of that is done through collaboration as well within the ICB, and also we are expecting to be doing more collaboration across the region in the months to come there. So please watch this space for more of an update in terms of how we proceed with that work. What I will say with regard to the off-framework usage is that nursing and midwifery have continued to maintain a very good position there in terms of that improvement and driving down that off-framework use, and we're seeing that that's predominantly now in the medical space. So we absolutely know where we need to target our work and where we need to focus that. The other notable area within the report that, again, there is considerable focus on is around colleague sickness. In particular, areas of concern are around sickness for stress and anxiety. We do know that we remain above pre-pandemic levels of reported sickness for those reasons, and we do have again, hotspot areas that we are really trying to support colleagues more proactively in. So healthcare support workers, nursing and midwifery in particular, we know that 1/3 of their reportable sickness is down to stress. So with that in mind, we have a number of interventions that are available to everybody within the workplace, but we are most recently looking at how we can better support our managers and our colleagues to have conversations about stress in the workplace, to actually find the right support to keep people at work and return people to the workplace who are struggling as well, in the most supportive way that we can do that. In general terms, across sickness, we do benchmark quite poorly nationally. So again, we are keeping our eyes on what's happening nationally and the best practice that we can also learn from across the country and the region to try and really target that as an area of focus.
Ali, it very much feels as though you've hit the road running on all of these issues. It's great to have you with us. Questions and perspectives, Colin?
Thank you, Chair. Ali, just delving into a bit more detail around the sickness absence point that you made, and in particular stress. So at board, we've heard previously about the offers the organisation makes to staff in terms of their well-being, both mental and physical. From your perspective, a few weeks in, comparing us with other organisations, are we doing as much as we should do?
I think we compare quite well, actually, compared to other organisations. So there does feel to be a good 360 of support, if you like, from that pastoral care and support to some of the more formal referrals and support through occupational health, and also psychological well-being provision for individuals as well. So I don't think there's anything that we're obviously not doing. I think it is just extremely difficult to really get hold of this as an area of sickness. We don't, for example, know there'll be multiple reasons why somebody might be experiencing stress. So we can't, for example, assume that it's all work-related stress, or vice versa, it's all home-related stress. And we really have to continue to look at that pastoral piece and that whole individual piece. For individuals in our organisation. I think part of the work that we'll be moving forward with around our culture will be really important in this space, to make sure that all colleagues within the trust feel that they can reach out for help, and that they can say if they're not feeling okay, and that we can try and catch people earlier to support them rather than after they've already gone off sick. And are outside of the organisation. So I do hope that will help us to care for our people in a much more robust way.
Okay, thank you, Ali. Chris, I'll only take questions from board members at the moment, so but very welcome to ask a question at the end. Richard?
Thanks, Ali, and it's great to see how fast you've been into the subject matter. So if let's say our vacancy rate is so low compared to the past, and we've actually got 300 less vacancies than last year, and our attrition is on plan, why don't we see the reduction in bank and agency?
I think that's a really good question. We know that we've got better control around nursing midwifery, and we know that we have some very tight workforce control there. I think where we aren't seeing a corresponding reduction is around medical agency use, and that's where we need that greater scrutiny now. And that will come down to looking at where we've got budgeted establishment, what the vacancy rates are in those individual areas, and balancing that against the specific agency use. There is also, of course, the pressure of unfunded areas, which will also contribute to that agency piece that we need to bear in mind. But we've seen this across a number of trusts in the country as well, that it doesn't always neatly correlate when you reduce vacancies, that you'll reduce that agency spend as well. And that's where our internal grip and control is so important. So we as a board certainly can understand better where that pressure's occurring and why that usage is there.
I think the other missing element is sickness, and you know, it would be good to get a little bit more granular detail, Ali, if we could, on sickness by staff grouping. I've said in the past, and the numbers I've seen previously, and I'd be surprised if it's changed, is that amongst our clinicians and consultants, the sickness levels are very low, and I would just like to thank them again for coming in when they're not feeling 100%, and their commitment to their patients. We're running a little bit behind now, but Glenn, and then we'll move on. Thank you, Ali.
Yeah, just picking up on your point, Chairman, on page 44 of 277, that the analysis of the reasons for sickness actually show the lowest levels of stress, anxiety, depression in terms of clinical areas in our urgent emergency care team. So it is interesting and, as you suggest, worthy of further analysis.
Yeah. Big opportunities, I think, in that area. Thank you, Ali. Thanks for your hard work, and looking forward to seeing the fruits of your efforts and labours even more so. So, Neil, we're almost at the financial year end. What would you like to pull out of your financial report?
Yeah, thanks, thanks, Russell. Just a couple of points to highlight for the board. So we previously have been reporting a 36.6 million deficit as a consequence of the last round of the industrial action. Pleased to say that we've now been funded for that additional 1.7 million costs, bringing us down to a projected deficit of 34.9. So we're 9 days after the year end. We're working through the month 12 position at this point, but I'm confident that we'll certainly remain within the 34.9. Month 11, we saw a deficit of 4.4 against the 2.3, and that left us the cumulative deficit today at 31.4. You'll see in the deck how that compared to what we had forecast in the month. So we forecast a 4.7 deficit, and we ended with a 4.4 deficit. You'll see the ups and downs there on page 47 of the report. I guess the key thing to point out is we had challenged ourselves in terms of a stretch, the financial recovery stretch, with our turnaround director, and we'd only achieved the 300 against the 1.5 that we'd set ourselves this month. So a bit more to do. So I'm hopeful that there'll be more of an upside in month 12 in that respect. We factored in this month the part of the risk, half of the risk around the shortfall in funding on the urgent emergency care business case, 800k. Again, I'm confident that we could accommodate that in month 12, but I'm still pursuing the ICB for the full funding in that respect. We've exited the year, we will exit the year based on the forecasts around the 10 million mark in terms of our cost and productivity improvement plan. Clearly, as we enter into next financial year, a much greater expectation, as there was at the outset of this financial year, in respect of CPIP. So we do need to see that step change, as we discussed this morning in the board development session. Just wanted to briefly touch on cash and capital, if I can, Chair. So cash, we have remained within our external finance limit. So tick in terms of one of those duties that we need to achieve. And in terms of our capital resource limit, board will recall that I briefed last time that we had been given access to an additional 2.9 million of capital resource which was well used in terms of some of our schemes that we weren't able to accommodate this year ourselves. And that subsequently the ICB needed 1.5 million of that. Pleased to say we've come to an arrangement with the ICB that we are within their collective overspend across the system. It's allowable, and I'm expecting either an adjustment to confirm that we are within our capital resource limits, or I think as we did last year, there will be a footnote to the accounts to confirm that within the allowable overspend. But pleased to say that we've maximised the ability to spend capital in line with the plan this year, which is some achievement based on some £48 million worth of capital resource. Happy to take questions, Chair.
Thanks, Neil. Any questions or perspectives to Neil? In summary, we're ending up as we expected to. Tony?
Thanks, Chair. Neil, I'll preface my question by saying that I am a trustee of CHEC, but it is in relation to the capital item on page 45 of the pack. I just wonder if you could explain to me what triggered the remeasurement of the value of the lease there and its liability. Thank you.
Yeah, so this is it's technical accounting treatment. So previously recorded as a finance lease, and now recorded as a revenue lease. But these are reflected in how the funds will flow from the department to cover that. It's a technical issue, but there is no impact on our overall bottom line as a consequence. So.
If you want to take it up outside, Tony, please do so. And Simon, then we'll move on.
Just an observation that we hit the target we said we were going to. I don't underestimate the challenge that was, challenges that were involved in doing that. A number of other trusts around the country have said things that they weren't able to do. We've got a long way to go, but at least we did what we said we were going to do. And I think that gives some certainty to partners who are working with us on other issues. Yeah, we did, of course, change it through half year, but point taken. Thank you, Simon. Any other points? Otherwise, we'll move on then and talk about the verbal update on the financial recovery plan, which we talked about this morning. Neil, what would you care to brief us on?
Yeah, so just for members of the public and the board, we've been working on a financial strategy in the background with the Financial Recovery Board, and indeed we presented to a couple of board development sessions now. So we've been working for the last 2 to 3 months on really getting to understand the drivers of our underlying deficit, which are quite significant, the degree to which we are in control of those underlying drivers of our deficit, to come up with a plan and a timeline of what is realistically achievable by the organisation. So we'll be bringing forward a plan for the public next time that articulates really the timeline, which will be the next 4 years, the residual deficit after 4 years that is beyond our control, we're not able to influence, and an understanding of the mix of productivity improvement, which is the way in which we'll also support delivery of some of our targets, but also in terms of some of the cash reduction, particularly in respect of some of the expensive workforce and what we can do around the edges in respect of our PFI contracts. So we'll be bringing that forward to the board for formal approval and engagement with the ICB and NHSE in due course, Chair.
I think the important thing, Neil, is we are being very aggressive for members of the public to be aware on our elective recovery work next year, because we do want to reduce down the waiting list for members of the public as quickly as we are able to. That will put enormous pressure on the operational side of our organisation, but it's exactly the right thing for our citizens. Glenn?
Yeah, so just picking up Neil's point about where we are in the planning cycle. Obviously, I mentioned earlier the planning guidance arrived late, and so the NHS is quite a condensed period of trying to ensure that we've got viable financial plans for this year. But that won't stop us issuing operational budgets out to all of our budget holders and divisions, and the discussions we'll be having with the system, and we'll be touching on these in our confidential section later. Just trying to hold the line on a stretch, but not impossible cost improvement plan for this year. So it's really important for this year that we put together a plan that makes progress, but that we do deliver on the organisation.
No, absolutely, Glenn. We need to be an organisation that delivers what we say we're going to deliver, but equally are demanding of ourselves. Okay, Neil, thank you for the hard work that I know is going on behind the scenes, not just with your team, but all the teams to bring together this plan. But as Glenn has sort of alluded to, it's absolutely essential for it to be pushed down and owned by the budget holders for the year ahead, to a degree that it hasn't in the past. We'll move on then to the perinatal report. And Justine, over to you.
Chair. Thank you. So this is the report for February. I just got a few, I'll take the paper as read, but I've just got about a handful of things that I just wanted to mention. We have met our booking by 12 plus 6 KPI for the first time since COVID, that we were able to report this, which is great news. And I can't see Vicky on the call, but actually I think some of this is around data cleansing and the increased performance from the informatics team. So just a thank you to her and her team for helping with that. Just to say also, we are really pleased to be able to report that we didn't report any stillbirth or neonatal deaths in February. And you'll see there that our perinatal mortality rate is now considerably lower than the national average, and our lower stillbirth rate is really driving that. And that is testament really to the implementation of Saving Babies' Lives. Our implementation rate is above 70%, and that is what is driving that improvement there. And hopefully that will continue. We didn't report any new cases to MNSI in month, and you'll see if we look at workforce KPIs, whilst there are still quite a few above the trust targets, they are all heading in the right direction and are much better than they have been in previous months. We received our CQC maternity survey last month, and I did say that I'd bring some of the report here this month, and you'll see it in the appendices. But just some headlines from our CQC maternity survey. We've improved in 10 of the questions, which was great news. We stayed the same in 39 questions, which is okay, but then there were no significant decreases in our performance in any of the questions at all. So overall an improvement, which is great. 3 areas again for our specific attention around information for the induction of labour pathway, pain management and family contact. And you'll know that we've already done a huge amount of work around the induction of labour pathway, more to come because we still are seeing delays. And also around family contact, because we opened up to open visiting in autumn time last year. I don't think that that was embedded at the time that this survey was completed. So I expect the actions that we've already put in place for 2 of those areas to show improvements in the survey that we're just about to take part in now. I've just mentioned delays in induction of labour, and you'll see that they feature there within the report, and they are red flags for us, and we do continue to have an issue with this. There is a quality improvement project underway, as I've said, and we are seeing some improvements in the general flow there, which is again will improve our performance with induction of labour delays alongside improved staffing as well, which you'll see in the report. CNST, we had just literally hot off the press last week received the Year 6 scheme, and I'll come back and update the board with that over time. We have now received confirmation from NHSR that we will be receiving some funding that we requested last year as part of our action plan, but we haven't yet had the amount confirmed. But I'm optimistic. Previously, we've received the full amount, so hopefully we will get that again this year. So I'll pause there and take any questions.
Any questions to Sue, Glenn, Justine rather?
Yeah, thanks, Justine, for the work we're doing. It's good to see some good indicators of quality there. One area that's a bit of a concern is the delays in induction of labour, as you highlighted. How does that benchmark compared to other providers, do you know?
We don't, because in the national tool, you can see that people declare that they have delays, but not the percentage of delays. So that's an area that the national team and the regional team in the SITREP are looking at. It's really difficult because there's different parts of the pathway in which women can become delayed. So it depends where you create your delay. Our bottleneck is at the point of transferring women to delivery suite for artificial rupture of membrane, and it's at that point that they need one-to-one care in labour, and if we're not able to provide that, then that causes a problem. And that is really driven by availability of midwives or flow out of labour ward, because obviously the more women that remain on labour ward longer, the less midwife time you have available. So those two things work hand in hand, and the number of women that you recommend induction of labour for, making sure that they're the right women and that they're counselled correctly. So you can see there's quite a lot of work going along in place there. I don't think we would consider ourselves an outlier, anecdotally talking to colleagues across the region, but we can improve on this because you can see it's increased month on month, really. We're expecting to see a decrease next month.
Thank you. I just wonder, Russell, whether that's maybe something we could look at 4 boards, actually, but we can probably get beneath the surface of the data a bit more.
I agree. And just 2 quick questions from me, Justine, because it's sometimes difficult to extract simple things from our collective board report. Just to make sure I've logged the numbers in my brain, how many babies do we deliver a month?
Well, it varies. Anything here between about 370 and 420 a month-ish, there or thereabouts.
Yeah, 400 was the number I had logged in my mind. Thank you. And what percentage of women require cesarean section?
Oh, that will change month on month. There's no national agreed indicator of performance around cesarean section anymore, Russell, but we'll see nationally, you'll see a rate changing anything between 30 to 45%.
Yeah, I know the national thing. I'd quite like to. Can you just let me know what our numbers are? Just drop me an email, Justine, if you could, because it's a number I log in my brain for each of the different trusts. So that would be great in the foundation group. Thank you. We'll move on then to safe staffing reports. And Sue and Justine, we're running a few minutes late, but what would you like to pull out of this report, Sue?
Thank you, Chair. So just a couple of points to pull out for assurance from the board that our staffing was safe throughout February 24, and that was across our inpatient areas, paediatrics and neonatals. Our temporary workforce demand is still being driven by our additional capacity and surge beds, and also our boarding, which has been used fully throughout February. As we've heard, just to highlight that our vacancy rates for registered nurses are really reduced. We're at 3.58%, which is the lowest in a very long time. And also our vacancy rates for healthcare support workers has reduced to under 10%, so that's good news. We're seeing our turnover rates for both those groups reducing as well, which hopefully is because we're able to retain our staff because there's more substantive in place. I think, as we've heard throughout the day, our work is ongoing to ensure controls are in place for the use of banking agency, and specifically that high cost agency. And just for board assurance, I've just done a quick look, and we used 40 hours of our high cost agency in January. That was on the bank holiday on New Year's Day, as was alluded to earlier. And then across February and March, we're down to a total of 23 hours for use of that high cost agency. So confident that, and that was in the paediatric area. So no general and acute areas that have used the high cost agency since January. So those are the main points I wanted to put out. Thank you.
No, great, Sue. Thank you. And Justine, anything you wanted to add?
Yeah, just wanted to pull out really. We were obviously just declaring that we were safe in February, but we did have a reliance on escalation and bringing our community and continuity colleagues in, and the impact obviously on the health and well-being of them, and the impact then on their workload going forward. And we have not used any agency since October 2023, just to confirm. because we were using some quite high cost agency last year. Nothing else to add. I'll just take any questions.
Thank you, Sue. Thank you, Justin. Questions and perspectives, Karen.
Thank you, Chair. It's just a quick one for Sue, just on that high cost agency, and I expect most of us know who you're talking about. I know that we work with NHS professionals as our link. So I am assuming, or my question is, do we have a threshold and algorithm where they come back to managers or whoever it is in the organisation before they go to those high cost agencies?
We do, yes, Karen. What we've actually done is taken those high cost agencies for nursing off the workflow. So it's a really specific process, so we have to go direct to them. All of our other agencies, our tier 3 and tier 4, which are our next highest agencies, are behind what we call golden keys. And it's only our matrons and above, so our directors of nursing, that can take those keys off. The tier 1 and tier 2 agencies can be released by the ward managers. And there's a specific time we've really reduced the time that those shifts are available to the agencies to see. So those are some of the control measures we've put in. And this month, what we're also doing is allowing bank workers to bump out agency bookings as well. So if an agency's booked in, a bank worker wants to do that shift, they can bump that agency nurse out of that shift. Just as another, just to reduce the cost there as well.
Lovely,
it's
thank
probably
you.
Worth just for members of the public being aware that NHS Professionals is effectively an agency, but it's owned by the Department of Health and Social Care. So most agencies are private businesses, often owned by private equity funds, often domiciled in foreign countries for tax purposes, but NHS Professionals is owned by the taxpayer. Glenn?
Yeah, the agency rates I was referring to earlier with the Thornbury agency, and this year we'll have spent about £800,000 with that particular agency. So just an indication of the opportunity to reinvest that in direct workforce.
And as you said, Glenn, their gross margins are probably in the region of about 50%. So that's a £400,000 at least loss to the NHS just from this one trust alone, and just to that one agency. Nurse agencies which are off framework are a parasite on the NHS. NHS agencies that work on framework are often very helpful and provide more flexibility, and we appreciate them working on framework. But when they're off framework, which means they can offer any price or charge any price they want, they really are a parasite. With that sort of political statement made, hopefully there were various different agencies listening into that, and I will no longer be on their Christmas card list, and that's good news. So are we happy then to move to the items for approval? Okay, so the first up is a scheme of delegation and standing financial instructions. Neil, anything you'd particularly like to pull out on this?
Yeah, so we've taken the opportunity to review scheme of delegation, standing financial instructions across the group to ensure consistency. Apologies for the long report, but it is necessary, obviously, to get it into the board. I've outlined there in the covering section all of the individual changes. The only one really that I'd like to put out is we've taken the opportunity here at Worcester to increase some of the approval limits. They were particularly low in respect of some of the divisional sign-off and directors sign-off. And we've amended some of those in the report. So just second questions, Chair. But they've been through the audit committee, been reviewed in detail for approval, please.
And Colin, I assume you're happy from the audit committee side?
Yes, I can confirm that, Chair.
Okay, thank you. So any questions on those, the scheme of delegation and financial instructions, standing financial instructions? If you're not happy to approve, could you please raise a digital hand? Duly approved. Then we've got the standing orders. Thank you, colleagues. Erica?
Yeah, along with the SFIs, these form the central pillar, I suppose, to govern the governance of the trust and regulate the proceedings and the business. We should all be following a model format. So we've used that to our advantage, and these standing orders will now be in use not just at Worcestershire Acute, but at George Eliot and at Wye Valley NHS Trust as well. The document hasn't been track changes because the extensive number of changes, but they're more it's more formatting. Procedurally, we should all be doing the same anyway. So we will now go ahead, subject to approval of the board, and promote the use of these key documents, the SFIs and the standing orders, to staff within the trust, so that they know that this is their sort of go-to source document for where they can get information on delegations of authority, etc.
Super, thank you very much. Any questions or perspectives to Erica on the standing orders? As Richard said, if Colin is happy. So if you're not happy to approve, could you please raise a digital hand? Duly approved, thank you. So we then move on to the EP, the Emergency Planning and Recovery Report. This is an annual submission. Helen, anything you particularly like to pull out?
No, not really, Russell, other than the fact it's a really positive report. We did well compared to last year on the EPRR standards, the core standard. So I'll just take it as read, and you can see that there's an awful lot of activity happened over the year.
Yeah, no, absolutely. Well done, Helen. Any questions or perspectives to Helen on the emergency planning report? If you're not happy to approve, could you please raise a digital hand? Okay, duly approved. Thank you, colleagues. And then we're on to the 24-25 objectives, which have gone through board workshop before, so we should all be familiar with this. It builds on the work we've undertaken on the 10-point plan and other bits of work we've been doing. Jo, anything you'd like to pull out?
No, thank you, Chair, for that introduction. So, as you've said, we did discuss these at the board development in March. We have reflected the feedback along with the executive feedback, and we've included a section under sustainability around our financial sustainability proposals. So just to remind the board, there are 4 key priorities for this coming year around flow and discharge, elective care, workforce and sustainability, and the layout and format. We've echoed one of our colleagues in the foundation group in terms of presentational style, but the detail and KPIs will be cascaded through the divisions in the usual manner down into individual PDRs following approval today. Thank you.
Thank you, Jo. Very clear. Any questions or perspectives to Jo? Tony.
Yeah, Joe, I just in view of the fact that we heard earlier that we had last minute guidance from NHS about this year's planning, just confirm there's nothing in that last minute guidance that's going to put the spanner in the works as far as we're concerned. Thanks.
No, not at all. There is a further strategy that I think was reported in Glenn's Chief Exec report around a longer term capital infrastructure review, but it doesn't affect our annual plans, no.
Okay, and Colin, thank you, Tony.
Similar, Chair, just seeking assurance from Jo that this triangulates as we would expect it to the financial strategy that we've considered, and in particular the bit that relates to sustainability.
No, absolutely. We've made sure we've triangulated, got consistency across the piece, Colin.
Yeah. The only thing I would add, Jo, and I'd say this particularly for members of the public, the NHS is and trusts are often given an enormous amount of things to do and priorities. Life being life is not everything is a priority. And as important as it is to state what your priorities are, it's also important to state what your priorities are not. So I'd always continue to encourage my executive colleagues to be clear with the board and members of the public on the things we would like to do, but frankly are not a priority and therefore we won't be doing, so that there's the limited scope for confusion, and that we continue what is, I think, a very important mantra of under-promising and over-delivering. So, Jo, thank you for that. If you're not happy to approve these 24-25 objectives, please raise a digital hand. Okay, super, duly approved. We've then got some items for noting and information. Richard, thank you for the communication report. Lovely to see the virtual tour of the Meadow Birth Centre. Anything else you'd particularly like to pull out for us?
Thanks, Chair. I take the paper as read. I'll mention briefly the successful launch of Exec Live, which we've now added to our raft of internal comms and engagement channels. Had a lot of positive feedback about that. A short paragraph on intranet too, but an enormous amount of work, both for my team in terms of mapping the content over, and also a shout out to Tom Brown and his team digital colleagues who've been offered invaluable support in developing the intranet. I think we are very close to being able to go live now. I need to do some more user testing and check a couple of access and search issues, but I think that will be hopefully a further good addition to the information cascade channels that we've got in the organisation. We've trained some of the first users in it and they seem very happy. And then a couple on the charity, the installation of the staff wellbeing areas at the Alex and Kidderminster, and we're now progressing plans to do something similar at Worcester, so hopefully those will be available in the not too distant future. And the work that's ongoing, which will probably come back to a future report, to build a more robust database of donors and engage more proactively with our generous supporters. So yeah, busy start to the year. I think from a comms point of view, coming back to the intranet, I'd be keen to get that pretty much done in terms of heavy lifting before we start the internal engagement exercise that we talked about at board from a capacity point of view. And we've also got some fairly big projects to support, including the rollout of the EPR in ED. In answer to Richard's question, yes, there is a record kept, and we cross-reference that with rumour mill as well. Colleagues who've watched won't be surprised to know that parking is amongst the hot topics that we provide regular updates on, but we also add things around catering, uniform and digital issues.
Thank you, Richard. Very comprehensive. Thank you and your team for your hard work. Any questions or perspectives to Richard? Okay, thank you. So we're then on, I think, to the committee summary reports and minutes. The first up is Equality Governance Committee. Julie, anything you'd like to pull out from the minutes of the 29th of Feb?
No, but we've had another meeting since then and we've sort of got a bit out of sync. I think the good thing about the March meeting was we did hear that there'd been an improvement in cleaning standards, which we've been tracking for some time now. So that was very pleasing. And also that the trust is going to be a pilot for Martha's Rule, which was introduced to allow people to go for a second opinion. So I think that's probably all I'd want to add from that.
No, great. And Martha's Rule, just for members of the public, is if you're a member of the public and you'd, correct me if I'm wrong, Julie, you'd like, or Jules or Julian, and you'd like a second opinion on a diagnosis or a prognosis, you can now request it and receive it. Is that correct? Super. Any questions to Julie on the February minutes and the March update? Thank you, Julie. And then we'll move on to the Audit and Assurance Committee minutes from February. Colin, anything you'd like to add to those?
Yes, Chair, thanks. Just to confirm to Richard, I am happy for the committee to recommend to the board the acceptance of the standing orders, SFIs, etc., which we've now approved. But that does come with a corollary in that they are requirements of staff, and we expect them to be complied with. And the audit committee receives on a regular basis examples or a list of those instances where they have not been complied with, either through a waiver or whether there's been a breach of these regulations and rules. And whilst in a lot of cases there are absolutely compelling reasons for that to happen, principally in some cases for patient safety, it isn't something that we rest easy on. And the committee is resolved to look at these in more detail. Neil and his team are focusing on these breaches because they are, by definition, only exceptions, and we should see them on a very restricted basis. And I think it's important for the board to set the mood music for the organisation that we expect people to comply, and that there may well be consequences when people don't. Thank you. That's all I wanted.
Point well made, Colin. Thank you. And questions or perspectives to Colin? Okay, we'll move on then to our People and Culture Committee. Karen, what would you like to put out of the last set of minutes, please?
So a couple of things. Just one thing from then. On the February meeting, we agreed and approved the on-call policy. At the subsequent meeting in April, we heard that there is now further review owing to some challenges to ensure that we get that right in terms of both the content and the implementation. So colleagues will hear more about that when you see the fuller minutes from the April meeting, and there's a robust plan in place with Ali and others in terms of making sure that that work is completed. So there's a slight pause on that policy, which is different from what was in the minutes. Just one thing, a couple of things to flag from the April meeting. We heard from the Freedom to Speak Up Guardian, and we have seen an increase in the number of concerns being raised. We're taking that as a positive sign of people feeling more comfortable in raising concerns, although there is still more work to do on those being made. At the moment, they're all anonymous, so we're wanting to understand what we can do to further that. And the final thing that we heard in April is a new proposed report in the same manner that we have a RES report and a WDES report around workforce statistics on race and disability. The organisation has pulled together a proposed report around sexual orientation in the same manner, which is not mandated yet. However, that is a positive approach to understanding where we are as an organisation in that context. You'll hear more about that when the fuller April minutes come along.
Super, thank you, Karen. Any questions or perspectives to Karen? Karen, if I understood the point properly on the on-call protocols, I would just encourage you and Ali to ensure that the protocols we use at Worcestershire are consistent with what happens elsewhere in the Foundation Group. Any other questions to Karen? Okay, super, thank you. And I'd also just like to say in this forum, my thanks to all of the different staff networks we have. We have some great networks within the organisation, our BAME network, our GBQT Plus network, and they do some really very important work amongst all of our different staff groups. So thank you for their endeavours. I think then, team, we're on to any other business. Any other business, please raise a digital hand. Okay, so can't see it. Oh, Julie.
Jules has just informed me that following further information, we're not eligible to apply to be a pilot for Martha's Law just yet. Some more information only came through last week. Jules knows more about it, or I will just read out the text she's just sent me, which seems silly.
Can I suggest we come back to it next month once we've absorbed it? But you're saying, Jules, we're not able to be a test bed, which would be a shame. But if we can clarify that in next month's minutes rather than cause confusion now, that would be super. Thank you. I got so excited then, gave my explanation about what it was, and it all went Pete Tong. Any questions from members of the public? Chris, your hand went up earlier and you politely put it down. But any questions from you?
Yeah, well, it was more a comment really, and apologies for interrupting earlier. I got carried away. First of all, I just wanted to actually recognise the positive improvements that have been made. You know, we do notice these things, and we do notice them, and obviously work continues, but we do want to actually recognise that. I think the area of most concern for us is around the workforce gaps, particularly when it comes to the to the fragile and vulnerable services. So I know that you're working on it, but it is an area that whenever I get involved in hearing what is going on, that seems to be a big factor that impacts not only on the outcomes, but also on the staff in place as well. It puts them under extra stress. I just wanted to comment on that. Thank you.
No, thank you, Chris. And we are conscious of, the exceptional efforts that staff in those fragile services go to do the best for our citizens. Glenn, anything you'd like to add on that?
Yes, we are grateful, Chair, because it's hard work in some of those areas. We are doing a piece of work across the group looking at fragile services, and there's particular opportunity around working with Wye Valley in some of these areas. I think it's also true that fragile services in one part of the NHS are also often fragile in others, but in some cases there's an opportunity to support each other. So that's something we'll report back to the board in due course as that piece of work progresses.
Absolutely, Glenn. We are part of a national health service, and arguably in the past that's maybe been forgotten in the way we've been organised, but we are part of a national health service and therefore should support one another and learn from one another. Okay, well, our next meeting as a board is the 11th of June, but we do have the full board meeting in May, the date of which escapes me at the moment, so hopefully Erica will tell me, and we will look forward to coming there. Chris, as you're the only member of the public on the line, I really would encourage Healthwatch to try and come along to that meeting. It's a different type of meeting with a real comparison across the different bits of the foundation group on a particular performance area. So I just think you'd find it interesting, and it is on the 2nd. It is on the 2nd of May. So thank you very much, everyone. I suggest we have a 10-minute comfort break, get back together again at 2:30 for the confidential board. Take care, everyone. Apologies. I always do this. I've forgotten that it's a trustee meeting.
I was going to let you do it as we did before, Russell.
Okay, so what
I think we've still got people here if you want to do it.
Oh no, it's just it's your meeting. I always forget. So are we quiet to do the trustee meeting quickly? Erica, are we quiet?
Yes, Chair.
Okay, so let's do the trustee meeting. I'm really sorry, Simon. I always forget. I apologise.
Not a problem. The report is as tabled. I think it's probably easy if I just answer any questions. I mean, it's fairly brief, but it tells you what we did at the last committee meeting. And as I say, I'm happy to answer any questions on any of those items.
Okay, any questions or perspectives to Simon?
We're making good progress.
Great. I think the only point I would make is one, and I know Simon, you and I are talking about it, is this issue of core funding. And Glenn and I had this discussion in other places. The NHS's funding is becoming more and more limited, and what would previously be described as core funding, there's no longer the funding for. And I do think there's when people give money to the hospital charities, it's coming back in. Welcome back, Mr. Burley. Sorry, I messed everything up again with this trustee meeting. I was just making a point, which is you've heard me make elsewhere, Glenn.
I think.
Can we just carry on running it, Erica? Sorry, I just had a text from Erica. I was making a point on core funding, Glenn, that there's discussions, I think, are going on in each of the charities about actually this should be core funding. And I know in particular, this often comes around chaplaincy services and end-of-life services. And I absolutely get that it should be core funding in the NHS. But Neil and my other finance directors in other places will say, but you can't have the money because there's not the funding. And so I do think there's a real discussion to be had in the charity about what's the right thing to do for our citizens when we're sitting on a lot of cash. Because particularly when it comes to end of life, if the NHS isn't providing great bereavement services, no one is. And that doesn't sit comfortably with me as a trustee member. So I'll just leave that for further discussion, because I know it's coming back on the next trustee meeting.
Yeah, I think if I could just add there on that more general point, and you're quite right, we had a good paper come, or good application come to us at the last committee, and we're having that resubmitted with a few tweaks, which will hopefully then get it through. We were aware, and I think all hospital charities were aware, that this particular financial year and financial years going forward would be very challenging for us with that area of what is core and what isn't core, because there isn't the money around that everybody would like to spend. We do scrutinise very closely every application that comes to us, and we try to be as flexible and as reasonable as we can, notwithstanding that we are having about £2 million of unrestricted money we could spend, but we are conscious of not setting precedents, of not setting in train things that would then become cost pressures for the trust more generally if we said 2 years funding for this particular project and it just rolls into our main budgets. It's a grey area. We're all looking at it. We do try to be as helpful as we can, and indeed the friends of the hospitals. I sat in at a meeting, the Friends of the Alex, having exactly the same discussion about a piece of kit they've been asked to fund. So it's an ongoing debate, but we were aware that these pressures were going to come because the money's just getting tighter and tighter. I can see Richard nodding his head. He was the one who alerted us to this some time ago.
Okay, team. Simon, if there's nothing else, I will allow us to get a quick stretch break and a cup of tea in, and see you in about 5-6 minutes.